Good morning. My name is Huie Lin, and I'm the Director of the Adult Congenital Heart Program here at Houston Methodist. And I'm thrilled to have an opportunity to share the recent advances that we've had in our collaboration with Siemens Healthineers. We're going to be talking about hands-free intracardiac echocardiography for structural heart interventions. So intracardiac echocardiography and the ability to automate it has the ability to potentially change the way we do structural heart interventions. So, for example, the first thing is that intracardiac echo actually requires a lot of time and a lot of attention, as well as a lot of technical skill and cognitive skill. Second, if we're able to do intracardiac echocardiography, we can potentially improve the patient's outcomes and potentially reduce the recovery time. And I'll tell you a little bit more about that in a minute. Further, the hospital potentially has the opportunity to benefit from it in that we can potentially move a lot of these cases to conscious sedation and decrease the cost and scheduling complexity, and we'll show a little case example of that. And then finally, of course, it can potentially increase the ability for us to demonstrate advances in technology. So let's start with a case. So this is a case from several years ago. She's a 73-year-old woman who was transferred with cardiogenic shock and acute myocardial infarction. So when she was being evaluated, it was found that she actually had a ventricular septal rupture, and you can actually see that here. Specifically, what you see is this is the left ventricle, and you can see color flow Doppler with flow going into the right ventricle here. And she was initially stabilized with mechanical support, but she continued to worsen over 24 hours. So this is how we actually approached it. At this point, the patient was not felt to be a surgical candidate, and so we went and closed her ventricular septal rupture with a device, as you can see here, in the cath lab. So how hard is this? Well, it turns out it actually takes a lot of people to do this case. So first of all, we have one operator at the neck to manipulate the catheters from the internal jugular vein. We have a second operator at the leg to manipulate catheters from the femoral artery. Third, we have an operator at the head to operate the transesophageal echocardiogram. And then fourth, of course, we have an anesthesiologist who needs to maintain the patient's safety throughout the entire procedure. And as you can see here, this is a very complicated case in that we actually also have an Impella mechanical support catheter in there to support the patient while we're doing this procedure. So the question is, can we do this with fewer resources despite the fact that this is a very complicated procedure? Can we even potentially avoid general anesthesia? And so this is where intracardiac echocardiography can potentially be of benefit. What we're looking at here is a catheter that sits in the right atrium that's advanced from the femoral vein. And what you're going to see here is the right atrium, the left atrium, and then color flow Doppler going through an atrial septal defect, which is a hole in the heart that the patient was born with. And what you see is a nice, very high resolution image of the structures and color flow Doppler going through the atrial septal defect. This is high resolution, real time, operator driven, and there are evolving 3D applications that could potentially really change the game. What you also see now here is that we've deployed a device to close that atrial septal defect, and we can drive most of the procedure from that standpoint to allow us to see the structures. However, as we're working, as you can imagine, since there are other things inside the right atrium, it requires continuous adjustment and manipulation. It can and has potentially damaged cardiovascular structures because it is another catheter that sits inside the heart. And most importantly, it really divides the attention of the operator between multiple imaging sources, from fluoroscopy, which is the video x-ray that we primarily work in, to the intracardiac echocardiography images that potentially require continuous adjustment to maintain the position and view that we're looking at. So we proposed a project over the last several years to develop a way to do robotic, actuated, automated intracardiac echocardiography. So the first was to develop a robotic actuator for semi-automated intracardiac echocardiography imaging. The second was then to do intracardiac echocardiography localization of the probe in 3D space so we could understand where we are and understand where we're looking. Finally, using these two technologies, we developed the concept of initial steps of automated echocardiography control. So let's look at the Ice Catheter itself, and let's look at what's required to control its automation. So first of all, what we're looking at here is the Ice Catheter itself, and what it allows you to do is posterior and anterior tilt of the catheter itself, rightward and leftward tilt of the catheter itself. And then, of course, because you can rotate the entire catheter left or right, you can face anteriorly or posteriorly. And then lastly, by advancing the catheter or pulling the catheter back and allows you to look superiorly and inferiorly in the heart. So these are all the things that the robot has to potentially control. And of course, this is what the current version of the robot looks like. And what you can see here is the manipulation of the actuator of the robot. And you can see its translation here, allowing us to look superiorly and inferiorly. Then above here, you can actually see the deflection of the catheter anteriorly and posteriorly, as well as left, right. What this allows for then is potentially a sterile system that is on the field, and then the non-sterile robotic actuator that is below the sterile drape of the field. So to allow us to better understand the position and the pose of the Ice catheter, our second goal was to take a CT and an MR data set to allow us to understand where's the catheter in 3D space, as well as to create a mesh of the heart to allow us to understand where is the catheter looking in 3D space. And so through a series of experiments where we mapped not only the heart of the porcine model, we also mapped the location, position, and pose of the intracardiac echocardiography catheter using CT and Dyna-CT to map its position and pose. And so what you see here is the view that we can see in ultrasound correlated with the position that's mapped by CT within a mesh constructed out of CT and MRI. And so what this allows us to do is to understand where is the catheter, where is it looking, and what do we actually see. And if we can put all of these together, we can potentially create a map that allows us to very powerfully understand what's going on inside the heart with the way the catheter is positioned. And of course, with that map, you can imagine how powerful that will be in terms of furthering our advances in automation. So ultimately, if we can do this, you can imagine that the future will allow us to create a co-registration with a 3D data set that's provided preoperatively, and that can give us extremely powerful understanding of where we are in 3D anatomy and guide the structural heart intervention. Potentially, this could be even a 4D data set if we do this correctly. Second of all, you can imagine that this 3D shell that's generated by the 3D data set could potentially create a safety corridor for full robotic navigation, so that way you can have the peace of mind that the robot is not going to exit that safety corridor in all of its manipulations, and you can increase the automation that the robot is allowed to do. So next, and this is probably the most exciting part of it, what we were able to do is create a series of images that allowed us to understand where we were, and then return the Ice catheter after movement of the Ice catheter back to that original view. And so what you're seeing here looks very uninteresting in that we had the initial view that I created. And remarkably uninteresting, of course, and that's what makes it so great, is that the robot was able to return back to that view despite us moving the catheter in multiple different directions at 10 minutes, 14 minutes, 18 minutes, and 21 minutes later without too much difference in the view. And I would argue that you can see almost exactly the same thing that we saw in the first view. So you can see the aortic valve here, again here, 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 and here. And importantly, for what I'll show you next, we can actually see the atrial septum. Again, this is the right atrium, this is the left atrium. And what this allowed us to do is to begin to confidently prepare for a situation where we can actually do a transseptal puncture. So a word about the transseptal puncture before we get there. So the transseptal puncture is a fundamental, foundational part of structural heart interventions. Why? Well, typically what we're able to do is we can advance a catheter from the femoral vein into the right atrium that can be actually pretty large and pretty bulky because the femoral vein can tolerate a lot of stretching. In addition to that, the angulation of coming from the right atrium is often perfect for many different interventions that we do, including atrial fibrillation ablation, mitral valve intervention, etc. Once we get into the right atrium, however, in order to get into the left side of the heart, a puncture needs to be made. That puncture can be done with either a mechanical needle or oftentimes these days an RF-driven needle that burns through the tissue here at the level of the atrial septum. You can imagine that this is a very low tolerance, very high risk part of the procedure and needs to be done very carefully with high power, high potency image driving of this procedure. So why is that? Well, it turns out that where you puncture in the septum is almost just as important as doing it safely. And so in order to do this correctly, oftentimes you have to move the intracardiac echocatheter from multiple different views to identify where you are in 3 dimensions, because typically today, standard intracardiac echo remains 2-dimensional. And so in order to get a sense of where it is in 3 dimensions, you have to change the view multiple times. And so our goal for this final version of the experiment was to see whether or not we could have the robot change views multiple times during a complete X-ray-less transseptal puncture. And so that's exactly what we're looking at here. So what we're doing here is initially one of the views, which is the SVC view. You can see the equipment getting ready in the right atrium. It's not quite exactly where we want it here, but through multiple changes in views, we were able to change the position of the transseptal puncture device and get it exactly where we want it to be. Next, what you see here is that we've now punctured. You can see we're still in the SVC view, but rest assured, in order to get here, what we did is we shifted back and forth between the SVC view and the aortic view. And then finally here, you can see we've gotten our interventional equipment across the atrial septum. You can see we're now in the aortic view here with the transseptal device across into the left atrium safely and without any evidence of pericardial effusion or perforation. So in order to do this, we had multiple swaps. This is at least 5+ swaps between the SVC and the aortic view to ensure that we were in the exact same place. And again, because we were doing this in the CT environment, we were unable to use X-ray during the procedure as we typically do in the cath lab. So this was a complete fluoroless, complete X-ray-less transseptal puncture. And of course, we used these automated shifts in the ultrasound views to ensure safe puncture location and to confirm its crossing. You can see that it's completely X-ray-less because here I am doing this experiment without wearing lead. So I hope that this presentation has convinced you that intracardiac echocardiography allows for excellent intracardiac visualization, but the challenge, of course, is that I have to have my hands on multiple different catheters during the procedure. And so therefore it divides and demands increased operator time, attention, and also requires a high level of skill to actually drive this. The potential of automating robotic intracardiac echo is vast and extremely powerful. The idea that it could be potentially driven by artificial intelligence and reflected back to image guidance has the potential to significantly increase the utility and the value of intracardiac echocardiography, as well as to really expand the types of procedures and the safety of the procedures that we can do with fewer resources and potentially increase patient safety. What we've demonstrated here today is the proof of concept that robotic automated intracardiac echocardiography guidance of critical structural heart procedures can be done with really minimal input from the operator so that the operator can provide their full attention to the actual critical procedure, mission critical procedure such as transseptal puncture. Thank you for your attention, and we'll take any questions.